So the default mode network is essentially that kind of organizing network of all of our autobiographical memories and all the stories that we have about who we are, essentially. And when that goes offline, obviously that can be very frightening for people. They can have ego death, or they can lose sense of self. They can lose connection to their body as well. And I think trying to prepare people as best we can for that is really, really important with psilocybin particularly.
Yeah. Okay. Hello, everyone, and welcome. We have something a little different today. We have a panel discussion about psychedelics and EMDR. And I want to start by having our panelists introduce themselves. So one more question. Why are we doing this? Why are we introducing mind-altering substances in conjunction with therapy? So Tiffany, do you want to start?
So I'm Tiffany Simmons. I'm a licensed professional and licensed addictions counselor. I have been doing ketamine-assisted EMDR. I'm also an EMDR consultant. I've been doing ketamine-assisted EMDR therapy for a couple years now. I also am the first cohort from Elemental Psychedelic here in Fort Collins, Colorado for Psilocybin-assisted psychotherapy, and have my trainee license from there. I've completed 7-month course, practicum and all of that. Work with complex trauma and love the integration of psychedelics to help further people's healing. I think, I work with a whole lot of complex trauma, dissociation, people that are really struggling I love EMDR so much. And even for that, some people's protective systems are too strong to be able to access some of the deeper healing. And so I love, from my first experience doing ketamine within it and being able to see how it kind of brings those protective parts down a bit and allows us access to things that otherwise can feel too scary to get to. And also stuff that's working. Being able to do pre-verbal stuff. I do that with EMDR, but I can do that so much better with the use of psychedelics.
Sounds good. Excellent. Next on the screen is Hannah. Good morning, Hannah.
Good morning. It's 5 a.m. here in Australia, so I'm just waking up. I am a clinical psychologist. So I work in a solo private practice. I'm an EMDR consultant, absolutely love EMDR. And I'm also a part-time psychedelic-assisted therapist. We're lucky enough here in Australia for both psilocybin and MDMA to be legal, albeit under very tight restrictions at the moment. So very lucky to be doing that work, and have used EMDR really successfully particularly with MDMA. I think it lends itself to blend very well because you can process emergent trauma that comes up on medicine days. I have found psilocybin particularly helpful for supporting people with bad trips. So yeah, that's why I'm here.
Okay. Gail.
Everybody, thank you for having me. I am Gail Neves. I'm a licensed mental health counselor, integrative trauma therapist, and an EMDR consultant and educator. My focus is on Psycholytic EMDR in my practice, and I really love the integration of different modalities with EMDR. I work primarily with ketamine, and I've been working with this medicine for the last 3.5 years, both with and without EMDR in different formats, and other trauma processing modalities as well that I've found really helpful, somatic attachment techniques, things like that. But I find that adding ketamine can be really helpful because sometimes folks really require a shift in how they experience themselves in the medicine sessions, and just even the smallest dose of ketamine can help them do that. Or alternatively, outside of a medicine session, days later, they have almost this new perspective, and it goes really well with trying to install new beliefs or shift some patterns. So I think there's a lot of different reasons and ways that ketamine can help support trauma processing.
Okay, thank you, Gail. And Andreas.
There we go. Hey guys, I'm Andreas Edrick. I'm a physician here in Denver, Colorado. I've worked with Rotem for many years, Tiffany, and as a physician, the bulk of my practice is addiction and psychiatry. I started as a family doc 25 years ago, quickly realized my real passion is actually more psychiatry and addiction and boarded in that. And that's really most of what we do, but we take a holistic stance. And when I work with you guys, my therapists, it's very, very critical that we honor what I call the recipe. And the recipe means we have to get the right ingredients at the right time, at the right ratios for the right client in the right season. And medications can be amazingly helpful. Ketamine has turned the world of what I do mostly, which is treatment resistant issues, into very manageable work. And that includes using not just medications and not just therapy. Also, I do transcranial deep brain magnetic stimulation for treatment resistance. Where the ketamine has come in is it's allowed patients, kind of like you said, Gail, to lower some of those defense mechanisms and allow them to go to areas that they wouldn't otherwise go to. And I always say the analogy I make is always, if I give somebody a muscle relaxer for a back spasm, the purpose of the muscle relaxer is not to go home and watch TV. The purpose of the muscle relaxer is so that their physical therapist can make better progress. That's why we say, take your muscle relaxer 30 minutes before you go to PT, and then the same work will be that much more effective, you know? And ketamine does exactly that, where it really allows people to be able to talk about and investigate trauma issues without the overlying emotional component that otherwise prevents. I've seen decades worth of work turn around in weeks to months, which has been amazing.
Yeah, so thank you, Andreas. So psychedelic medicines are really powerful. And I, a couple of months ago, went to the psychedelic science conference that was, luckily for me, was here in Denver. So I had to, a short drive. Hannah came all the way from Australia and I got to meet her in person. And in the conference, there was a lot of research, a lot of conversations about different kinds of psychedelic medicines. There's ibogaine, there's DMT, there's 5-MeO DMT. There's a lot of psychedelic medicines. What we're going to focus on today is talk about 3 medicines, which is psilocybin, MDMA, and ketamine. And for those who are, I guess, in most places in the world, ketamine is the most available one. And I want to start by talking about, when we were off mic, the 5 of us, we talked about safety and how things feel a little unbalanced now with what's going on with the state of the world and the state of the world in terms of psychedelic medicines and how ketamine is being prescribed and delivered in the mail, and there's not a lot of oversight. What are your old thoughts about what's going on in terms of how ketamine is being provided now, and what is your approach? So what do you think the right way to do it is?
Okay. I was just going to say, I think I've had concern from the beginning with a lot of the online programs. I ended up going through and using one, and my husband did, just to get more information and kind of see what they do. And there's not a lot of oversight, a lot of safety. They're mailing large amounts all at once, which is definitely not ideal, especially when we're not even making sure that people have therapeutic support. We were also discussing, I'm concerned too of what that's going to mean for regulation down the line, because there's so much of a get rich quick, that and infusion clinics around here too. Do the infusion, you don't really get much of any support, you leave. Yes, there's anti-anxiety and antidepressive effects of the medicine itself, but then people aren't actually getting better, it's just maintaining. So with my clients, I like working. Well, like Andres, I have a couple providers that, we have a very collaborative relationship and able to make sure that we're getting the right dose for people, that we're checking in that they're using it appropriately.
Yeah, it's the same with every other disease. It's no different. We don't just mail out insulin with no guidance. We don't just mail out physical therapy exercises with no guidance. It's not proper. It's not ethical. It's not the way to do it, Can you cut corners and get away with it at times? Sure, you can. And, that's the direction it's going. I don't know that we can necessarily stop that in a country where The almighty dollar is much more important than ethical treatment. Like I was telling you guys, when the Attorney General asks me to review doctors that overprescribe or companies, that's usually when it hits the fan, when it turns out that there's no bona fide patient-doctor relationship. That must be present. It must be present. And they're trying to skim off the surface and hope that they don't get caught. And it's just bad for the patient. Don't get me wrong, a business is there to make money. We all run businesses, but there's plenty of business out there if you do things properly and take it one patient at a time, and the success, because the problem is that we're going to see false conclusions again when people say, oh, look, Prozac didn't work. Oh, I've done therapy, it never works, it doesn't work. No, you've done the wrong recipe. That means you either used the wrong medications and the wrong combination and the wrong ratios. You didn't do the right kind of therapy with the right kind of therapist. It wasn't supported properly. There were other things that were holding you back, like alcohol and so forth. And your conclusion was incorrect, which is the tools don't work. And I always tell patients, look, if the soup turns out too salty, don't blame the salt. It's not the salt's fault. It's the chef's fault, or the recipe sucks. But stop blaming the salt, okay?
Yeah. I like your analogy about the muscle relaxer, and you're not giving the muscle relaxer as the be all and all solution. You're giving the muscle relaxer so the person can actually do the work to get better. Which brings me to in EMDR we work under the assumption that we have an internal healing mechanism, that our brain and nervous system and body can heal themselves. I'm curious, Gail or Hannah, what are your thoughts on that? How do you use the medicines? And I know, Hannah, you can share a little bit more about MDMA and psilocybin, which you're lucky to work with, or Gail, talk about your work with ketamine.
Sure, yeah. And just to go off of Andreas and Tiffany too, I think the mass prescribing of ketamine without that middle, like we're cutting out the middle of the relational piece, where we have, we're tracking and following, is this the right approach? Is this the right thing for you right now? And this, lack of kind of screening, folks who are seeking out these kinds of treatments are often very vulnerable. They've tried other things. And so, to just give them a bunch of ketamine and like hope for the best sounds like, ooh, just really poor care. But I really like I have a lot of screening tools that I use when folks reach out to me, or even just like I'm considering offering this to someone who's in my practice. And when I send someone for a ketamine evaluation, I understand that they may come out of that evaluation with a completely different referral, because depending on what's going on for them, low dose ketamine and EMDR might not be what they need. They might need Spravato or a completely different medication. And so just kind of looking at the whole person and what else could be going on when we're sending folks for these medical evaluations, I think is important. I think that ketamine can help people access non-ordinary consciousness, which is where some really beautiful things can shift and occur. We can do that without the medicine. The medicine helps us to be able to get there and stay there. So it's a nice additive to an already very enriching treatment process. I like EMDR without the medicine, but I do like the psycholytic approaches for that reason, because it can help people achieve that non-ordinary space and have that new experience of themselves there.
Thank you.
I'm just here thinking, I'm so glad that we don't have these really loose guidelines around ketamine here in Australia. I mean, I mainly work with people with complex trauma, and I would be horrified to think of them having ketamine mailed out to them and not having any support around that. So, I mean, I can speak a bit to our guidelines around psilocybin and MDMA rotum. I don't know if it's the right time to do that, but
yeah, it's the right time. And I want to say one more thing I learned at the conference, and I talked to you when we met at the conference, that both psilocybin and MDMA were approved in Australia on July 1st, 2023. But since then, there are only about 100, maybe 100 and some change patients that have been treated. So maybe you can talk a little bit about that.
Yes, that's right. We've gone very slowly and cautiously in Australia. I think the rescheduling of the medicines caught lots of people by surprise. And in Australia, we weren't particularly, forward in our research in psychedelics at the time. So I'm glad that we've gone very cautiously. At the moment, we don't have so many authorised prescribers who are the psychiatrists who are allowed to prescribe the medicines. So that's kind of one reason. And I think it's been wise to go very slowly and cautiously. So I'd say that everybody in Australia, I certainly kind of acknowledge my beginner status in this field. And I think we're all beginners, we're all learning from each other. And particularly in combining EMDR and psychedelics, we know that, there is not very much, well, hardly any research or evidence apart from case studies around this. So I think we do need to be really cautious about combining the two. They're both evidence-based approaches, but how we combine these two powerful approaches, I think, we have a long way to go.
Yeah.
Yeah, like you and I, Rotem, when we work together in Tiffany, and each time we dispense a dose and then we talk about it a day or so after the treatment, that feedback for me is so how do I know what dose a patient needs? We've had it across the board, and we sort of, like you said, Tiffany, we're kind of flying by the seat of our pants. The AG's office will ask me once in a while, like, how do you define standard of care? Because that's how we judge whether or not a physician is treating properly. And I said, standard of care is, the definition is what most other physicians would do in similar circumstances. And I said, do you see the problem now? This is the beginning, and like, we don't have enough people, and we're just kind of all flying by the seat of our pants. I said, basically, standard of care is whatever I'm going to pretty much tell you over the next couple of months as we're working this. And Rotem and I we've all been kind of figuring out, hey, what's the right dose? What's a cautious? What's an ethical approach? What's dangerous? We've seen people get over sedated on that stuff, and what kind of exceptions are there? But again, it's just like any other thing. I need feedback from my physical therapist, how their exercises, how are the joints going? How are the muscles? Are they making progress? Are my muscle relaxers helping? Maybe we should switch to an anti-inflammatory, But not only do you want to make progress, but you also want to keep the progress. Okay. It's not about just making progress. We want to hold on to the progress. And the same for TMS. Sometimes we make progress, but if you don't have the supporting tools, and I always say the word tools because I'm a doctor, I'm not just talking about medication. Sometimes people say, oh, you're a doctor, you're just here to throw pills at me. Like, no, the recipe says that no one ingredient is more or less important than another. Prozac is not more important than therapy. Therapy is not more important than proper sleep or getting some exercise or maybe looking at supplementation, or like, they're all differently important. You better get the right ratios of all of them and the right timing for the right patient, because remember, we only get 2 grades in life. A+ or F-. There's no in between. And I don't care who you're talking to, whether it's a chef, a plumber, a dentist, or an engineer. Remember those rockets that blow up when they're going out? A lot of times there's one little error. Okay. You can get 99% of the recipe right, and it doesn't turn out properly. And their conclusion is, it doesn't work. And that's my biggest fear with these fly-by-night operations, is they're really not doing the diligent work to make sure what's the best shot for patients. And that's what you guys need to work on, because I need you guys as therapists to give me that feedback. Otherwise, I'm just guessing in the dark, or the patient just comes with whatever they think they need. And Tiffany, I think we've had a few where patients think they need 4 times the dose, but the therapist is like, actually, we've made some pretty good progress here, That's the nature of a dissociated. When you're dissociated, you don't really have the insight to know how it went necessarily, So,
Yeah. Yeah, I want to talk about the lowering of defenses that was mentioned already. And maybe, Gail, you work primarily with low dose ketamine. So I want to hear from you what you see in terms of lowering of defenses. And then, Hannah, I'm curious to hear from you. How does MDMA and psilocybin work in that context of lowering defenses?
That would be great to hear, because we don't have access to much of that.
Well, I'm happy to talk about this. And I want to be careful about my language, because I want to honor some of the defenses, that they're there in protection of things that brain has put in place for a reason. And, we got to respect the brain for what it does. So I pulled from this really great training I did a few years ago that was a Frank Anderson complex trauma, IFS for complex trauma. And, back when I started doing my EMDR intensives, I was like, this is going to be perfect. I'll bring this in, this idea of parts permission. So, that just seamlessly came through when I started doing my medicine work, was asking parts for permission talk about certain things, to decide what we're focusing on for the intention. And then, of course, when we're doing the dosing sessions, as we're, the clients are self-administering, or, I work at a clinic where we use IM injections, let's just get some permission and check in. And then, yes, with the parts saying, with all parts on board and saying this feels okay, we can lower the reactivity. The medicine can help for any residual reactivity that could come up while we're targeting a memory network, right? So it allows for there to be some spaciousness. It also allows for some like ease and creativity. I believe it's like a portal to this transpersonal space, even with ketamine, even though it's not a plant medicine, but it really can help people feel connected to something bigger when they're going somewhere deeper, right? So I don't know, I think as clinicians, we can set the tone for really honoring and respecting what the client brings with their defenses and all, and work with those parts. And then, really inviting those parts to bring to the table, what are the pieces that are going to help you to be able to access non-ordinary consciousness, so that we can start to shift some of these beliefs using EMDR, using some of the other protocols that we know, IFS, things like that.
Yeah, and I agree 100% with what you said about defenses. And there's a reason why many of our clients, some of us, do have these defenses, right? They were developed for a good reason. They're part of our system, and we have to honor them, and we have to work with them. And sometimes it's helpful to lower them. Again, each client, we have to really carefully assess what these defenses and why they're there, and what their functionality is for this individual client, and then work with lowering them with the medicine. Hannah, what have you seen in terms of MDMA and psilocybin in terms of defenses?
Wow, so much that I could say about this. And Gail, I love the way that you've framed the parts work approach, seeking permission from all parts. I think that's really important, and honouring protectors and the amazing role that they've done to get the person to where they are today. So I certainly try to do that in my work as well. Obviously, it's very hard to get permission from all parts going into medicine work, because parts don't know what they're going to be up against on medicine day, because on dosing day here we use very high amounts of psilocybin or MDMA. So I think with MDMA, obviously the effect of the medicine is that switches off the amygdala, and hopefully somebody feels a softening in their body and an allowance of being able to go to their trauma without as much kind of difficulty in the body. Doesn't always happen that way in my experience, but certainly protector parts very much go offline in an MDMA assisted therapy session on dosing day, and that can be very surprising to people. Perhaps not while the medicine is on board, but afterwards people can be very shocked and surprised at how deep they can go into their trauma without the protector parts online. Similarly, with psilocybin, we give a high dose. We know that switches off the default mode network, or that's our best guess about one of the ways that this medicine works. And of course, that can also mean that certainly protector parts go offline on a medicine day with psilocybin, and people can come into contact with younger parts or exiles their trauma, and then that's something that we need to try and make sense of and work through afterwards.
Yeah, you mentioned the default mode network. Tiffany, I'll get to you in a minute, because I do want to talk about, psilocybin in the United States, in Colorado and Oregon and all that. But to a point you mentioned, Hannah, you mentioned the default mode network. Do you want to maybe say a word or two about the default mode network? What is it, and what happens when the default mode network quiets down or goes offline, or whatever way you want to?
So the default mode network is essentially that kind of organizing network of all of our autobiographical memories and all the stories that we have about who we are, essentially. And when that goes offline, obviously that can be very frightening for people. They can have ego death, or they can lose sense of self. They can lose connection to their body as well. And I think trying to prepare people as best we can for that is really, really important with psilocybin particularly.
Yeah. Okay. If you want to learn more about the default mode network and just about psychedelic assisted EMDR therapy in general, about the science and the application, there's a relatively new book called Psychedelic Assisted EMDR Therapy by Hannah Rain Smith and Jocelyn Rose. Jocelyn is actually joining us live now from the UK. Tiffany, let's talk about psilocybin training practice in Colorado. So three of us, Andreas, Tiffany, and I, are in the United States, in the great state of Colorado, where some psychedelic medicines have been legalized, not just decriminalized, legalized. Tiffany, do you want to talk about the training you did and share a little bit about your experience?
Yeah. So we decriminalized for personal use, and then last year, it's been a gradual rollout, but really started working on what the licensure path looks like to use it therapeutically. Prior to that, I was able to do some work with people where it was personal use. They're using, and I'm just there to support. But there's several different programs. I really loved the one that I participated in. It was 6 or 7 months, and we actually had experientials and got to even before practicum, we're able to do like a practice sitting for each other. The licensure path right now, you complete the training program, you then have to do 40 hours of a practicum following the training program, and then 50 hours of consultation, and you have 2 years to get your full license at that point. They have it to where, I'm a little bummed about this, but they ended up deciding in the regulations that psilocybin can only be used in the context of healing centers, so specific centers that are set up. There will be places that like rent out their space to others. They're not allowing home care unless it's an ADA thing, which initially there had been some openness of being able to go into people's homes to do it. It's still a work in progress and figuring out what it's going to look like across the board. So for example, here in Greeley, my city council made the decision acknowledging that they had done no research, but that they knew what was best for Greeley and decided to zone in a way that made it virtually impossible to have a healing center here. There's also some just considerations to note in there because it is still federally illegal. There are some issues with, like, I have a mortgage that's an FDIC mortgage, and so I couldn't actually turn my space into a healing center because we're federally insured and it's still federally illegal. So it's still work in progress, but getting there.
It's very complex. In the Psychedelic Science Conference, I went to a few talks that people from Oregon and people from Colorado participated. They had panels. This is why we're doing the panel, by the way. I was inspired by these panels that, you bring a group of people together and you have a conversation. So there's constant conversation between Colorado and Oregon, and we're trying to learn from each other. One of the exciting things that are going to happen in Colorado now is data collection in a positive context when it comes to psilocybin treatment. So far, psilocybin is, Schedule 1 drug in the United States, which means that there's no medical benefits and there's a lot of potential harm. So far, all the data that was collected on psilocybin was in a negative context, how it harms people. And the state of Colorado will do the first project of collecting data of how people improve as a result of this treatment, which I think is exciting.
I did want to add one thing that I appreciate that Colorado is trying to do with it as well. I mean, because there's some in their execution, but as part of someone doing psilocybin, you have to include an integration session in your pricing and in that bundle to ensure that that's actually happening, which I appreciate. And I was just going to say, in order for this to also not become like the ketamine thing, I think really the importance of preparation, of ongoing things. Like I won't do medicine work, either one, with someone who just called me and is like, hey, I want to do this. Like, I have a therapeutic relationship, and if it's appropriate, we're adding that in. Because I think that some of the get rich quick is like, just, oh yeah, sure, you can come from out of state. We'll do a journey over the weekend, and best of luck to you.
Yeah.
Yes, I want to talk about that. I want to hear more about preparation and integration. So preparation is, I guess, familiar to most people who watch this because, we have preparation phase 2 in EMDR. But what are the correlates maybe of preparation when you look at psychedelic work and EMDR work? And what is the role of integration?
Gail, you looked excited. I'm going to start.
Go for it,
Yeah,
Gail.
I love talking about this. This is like my passion. So, with the addition of psychedelic medicines, and I'll just preface by saying, for me, I do a lot of like combining together at the same time, EMDR and medicine, which not a lot of people do and definitely has its own flavor. But the preparation work includes a lot of information about the side effects of the medication. Like, this is assuming that they've been evaluated and they meet criteria and they're a good fit for the medicine. We talk about, what are some things that will be happening for you biologically, and how long will it last, and what are some things that you can do before doing this that are going to help prime your brain so that you're going into it with a beginner's mindset. You're not like clouded by watching, cartoons till midnight the night before, and that's all in your psyche. And so just helping people to kind of clear the space starting days before, and then absolutely doing the resourcing with folks, getting very clear about, if things go sideways, what are some things that are going to help us to kind of come back, to feel grounded, to feel resourced. There's a lot that's in between there in preparation sessions. I feel like mostly just really making space for questions and reviewing expectations. And we do this in regular medicine work, like putting it up front, like, what if this doesn't work out the way that you thought? Can we talk about Can we manage what can happen on the other side if it doesn't feel the way that you want it to feel, or you actually get completely new information and now you're going in a different direction with your healing, and how would that be for you?
I think that's critical for me too, because if you guys don't do the prep, if you don't set the table properly, and if I don't set the table from my angle and you from your angle, and the patient goes through the bad experience, we're souring the field for any, like you said, Gail, any future possibilities. If I say, hey, okay, this didn't go the way we expected, how do you feel about doing deep brain magnetic stimulation? We're going to have a whole different approach, and we're going to really sour that field if we haven't set the table properly. And most patients, if they have side effects, if I set the table ahead of time, they'll call me and say, guess what? We were talking about that little bit of diarrhea thing. Yeah, that showed up. Or a little bit of that dizziness thing. Yeah, it showed up, but you said it's not a big deal. So it really helps alleviate some of their fears, because fear is one of the big things they're coming in with. We don't want to add that. We don't want to add the unknown. They don't like the unknown. If they're prepared for stuff, most of our patients do fine.
Yeah, I appreciate so much your perspective, Andreas, because I know you're a medical doctor. I always forget, but it's the American Association of Ketamine Physicians or something like that.
Yeah.
I got it right?
Yeah.
Oh my God,
Pretty
I
close.
got it right this time.
Right. Yeah.
So I think doctors tend to think in terms of what is the efficacy of the chemical, the molecule, right? Like how, and that's how most research studies are being done, right? Like how does the medicine affect? They're looking for correlations between the dose, let's say the dose and the type of medicine to the improvement in symptoms. But we have a big part of what we do, and this is why these medicines are very different from other medications, is that we're looking at the set and setting. I'm wondering, Hannah or Tiffany, do you want to talk about set and setting? What is it? What is the set and setting, and why is that so important?
Okay, so we know that set and setting have a really big impact on somebody's experience. So set is the mindset usually that somebody comes into the medicine session with. And I think that kind of links into what Gail was saying about the importance of preparation. So important that somebody is prepared, because that can help them to have a positive mindset, which has a huge impact on their experience on the day, particularly when we're giving really high doses of the medicine. And the setting, we know, also has a really important part to play, particularly on medicine day. And that's really about, whatever is in the environment. So here in Australia, we tend to use kind of really soft and gentle settings, and we use people have eye shades so that they can go inward and they can be really internal with the medicine and the experience. And we also use music as well to enhance people's journeys. So everything, all of those kind of factors can really play into somebody's experience. So it's really important to be mindful of those, both set and setting, I think.
I'm also going to add in their piece of the set and setting that I don't know that we always have a lot of focus on, and me too, is also where we as practitioners are coming in and what our energy level is. If I'm exhausted, if I'm frustrated, if I'm whatever, I'm not able to hold that space. And so making sure that we're also checking ourselves and taking care of ourselves so that we can walk in and be able to hold that space in the way that the person needs.
Absolutely. I think so. I did a mistake one time of doing 2 ketamine sessions in one day, and I'm never gonna do it again because the second one didn't get the 100% of what they needed from me on an energetic level. So this is important. Gail, do you want to talk about the therapeutic relationship in the context of set and setting? Do you see the therapeutic relationship as part of it?
Absolutely. Yeah, I think especially in the context of like consent too, right? Like creating an environment where there's a little bit the power dynamic, there's a hierarchy shift, right? So if you're working with somebody, especially that had experienced trauma in, you know, any kind of like coercive experiences, that stuff's going to get kicked up by itself. So like, I think as part of the preparation or just even throughout the treatment, to be really thoughtful about making sure your client has agency and can feel like they're in control and really managing every step of the way and giving consent. And that's part of keeping that relational container really safe and open and like breathable. And I think, I don't know, it's an interesting thing. Unless you've, you know, have done some guiding or you yourself have had a medicine session, it's hard to wrap your head around how to be there for somebody in this way where like you are keeping them safe and you're managing that space for them, even with EMDR, but you don't want them to feel like they are, you know, too vulnerable. Like you want them to feel empowered and that they have choice through all parts of it. So I think that's really important. The medicine, once you take this medicine, you can't give consent, right? So like working psycholytically, even with just like small doses of ketamine, that still alters folks' perceptions around what's okay. And, you know, especially when we're doing like positive cognition installation and all of those pieces, right? Like everything has to come from the client. It has to come from the source where it makes the most sense that they're not feeling coerced or mentally manipulated or anything like that. So I think there's a lot of nuances in there. I have other places where I've said more about this and talked about this, which we can maybe come back to another time. I want to hear what other folks have to say about this as well.
I think it's interesting because, sorry. What I see is those protectors, which again, I spent a lot of time with patients honoring that they have done a good job so far. They've made it 40 years throughout life so far. But then what I see protectors building upon protectors. You know, I take care of a lot of the sex trafficking folks here in Colorado, and when these ladies come in, it's just one layer of protection built on top of another, and how like it's difficult for me to even see how do you guys remove those layers slowly one by one, the ones that were not helpful before. They're more collateral damage, you know, but here they are. You come in the door, you have 10 different layers, and those need to be pulled apart. And yet we still have to somehow have an element of consent going on for them to understand. Like, do they even know where they're heading? I don't know that after 20 years of being sex trafficked, that it's easy for them to even understand, like, where are we heading with this? How do you consent to something that you've been traumatized 10,000 ways to the wind for decades? You know, that's just got to be challenging, you know?
Yeah, I do want to say that this work, as much as, you know, when you look at the media, you see a lot of kind of like the quick fix approach. Like you do that, you know, all these people did one session of psilocybin or went to ayahuasca retreat and, you know, all their problems were gone in one weekend. And it's not always like that. I start to see, you know, we call a therapeutic session with medicine a journey. And I started seeing the whole treatment as a journey, not just the actual session, because it's important to see what's coming after the integration session and what do you do with what came up? What work do you do? Tiffany, you wanted to say something, so maybe you can say that and also reflect on what I interested in how you do this with EMDR specifically.
So one thing, just for what you were saying, is I wanted to throw out there, it's very much like EMDR, right? We have people who talk about single incident trauma and they went in 1 or 2 sessions of EMDR and everything is better. And oh my goodness, they're sleeping again. Most of our people are complex trauma people, that it's going to be a longer arc. And similar to EMDR again, is like sometimes integration from previous medicine sessions is happening in future medicine sessions. So it is a longer arc. I also wanted to just speak real fast to what Gail was saying as well. It's like literally when we're talking preparation, like everything is discussed. What does touch look like? How would you ask for that? What's appropriate? If you need to go to the bathroom, what are we going to do then? If you don't like the music, like we're talking through all of these details so that once they get in, they know for what they need, how to say no. And as you said, right, that they've consented at a point where they can consent, because then if someone asks when they're like, I don't want to be touched on them, it's suddenly like, oh yeah, that'd be fine. If we haven't already consented to it, this isn't the time, and we can process that after. Also, the reality is within medicine work, there's a history of sexual abuse when people are under the influence, and understanding that piece. I offer to all of my people. I haven't had anyone who took me up on it, but I always offer, if you want me to record, I will. Not for any other reason than you have it and you can know what happened. And usually they go, well, I don't want to see me in that. Like if I'm being weird or whatever else. And I go, it's for your safety, that accountability is okay. Yeah. And then you said talking to just EMDR specifically, or
yeah, just specifically the EMDR work. Maybe you can share a little bit about work that you did with a certain client, or just what you do in general, how you integrate the two.
So it looks different between ketamine and psilocybin for me. So ketamine, I do EMDR before, during, after, like it's in all the things, but like within medicine session, like I usually will do about an hour of where they're really in the journey and they're doing that on their own. And then we move into some EMDR. It's not the super structured full assessment on target or anything, but what's coming up. And we can use EMDR to facilitate in that. I personally have never done it with psilocybin journey. However, EMDR is beautiful for helping with integration from stuff that came up in the journey.
Yeah.
It would be cool to be able to participate in that psilocybin sometime soon. Anna, you guys definitely have a benefit over there.
We do.
Yeah. And to be able to choose, Hannah, tell us maybe where do you find one works better than how do you choose, and what is your decisions based on?
Yeah, that's such a great question, because so the guidelines here in Australia are very strict. So MDMA is for PTSD, and psilocybin is for treatment-resistant depression. So, but interestingly, lots of the clients that we see are very complex. They could meet criteria for both. Luckily, it's not me that has to decide which medicine is given to a person. That's the psychiatrist's kind of decision. And I've been reflecting a lot lately about, which kind of group of clients would benefit from which medicine, really, based on the limited experience I've had to date. And I would say, I think we're seeing that MDMA tends to be a little bit softer and gentler, particularly for people who've got complex trauma. Going into a very high dose psilocybin session, even if we try and prepare them as best we can be very confronting for them. So we have had people who have had a combination of medicines, not at the same time, but may have started with MDMA and then come back for psilocybin. Yeah, so that's been really interesting. But yeah, we're very, very lucky to be able to use both medicines.
Give us an example of like psilocybin where it goes sideways or goes bad. Like, what dangers have you experienced?
Well, I mean, I guess we've been very lucky here. We've had no kind of extended adverse events in any of the clients that have been treated in Australia. So that's just wonderful. Of course, there can be really challenging experiences for people. And I think that may possibly speak to a lack of preparation sometimes. Some clients come to us not having had very much therapy even before. So you can imagine they're not psychologically minded. It can be a lot for them to go into a psilocybin session. And, as best as we can try and prepare people, nobody really knows what it feels like until they have the medicine. So we've had people who've had some very challenging experiences on medicine day, but here we're very lucky to be able to continue to help people integrate those experiences. And, just from talking to colleagues, obviously I'm not across all of the 100 people who've been treated because that's across Australia, but just from talking to colleagues and in supervisions and things, I think that having time to unpack things afterwards has been really beneficial for people.
Yeah, I think, Hannah, I think you
Sure.
said we were lucky twice. And I think it's more than luck because you've been doing, you meaning Australians, not just doing a really good job screening and really trying to find the right patients. And I think for a very good reason. And you have to find that balance, right? On one hand, you want to make it available to more people who need the medicine or can benefit from the medicine. On the other hand, you don't want to harm people.
No.
And I want to bring up HPPD. So HPPD is a hallucinogen persisting perception disorder. This is something that sometimes happens after psychedelic treatment. I went to a couple lectures in the Psychedelic Science conference about HPPD. One was more research, and there is not a lot of research. The etiology or the causes of HPPD are not completely known. They're looking for genetic components, but there are some screening tools that we can use to at least reduce the chance of causing our patients HPPD. The other talk that I went to was really interesting. So it was a woman, a clinician from Canada, who went to get treatment and got HPPD, and she had a horrible, horrible experience. So think about, you do this treatment, then you're kind of stuck in a psychedelic state. So you constantly going through derealization, depersonalization. Her mood was really low. She was constantly crying for months after the treatment. And not a lot of people, I think not enough people are talking about it, that this is a possibility. Because when you see the good results, you get really excited. I can speak for myself, right? I get really excited. And some people might think, oh, everyone should do that because it's so good and it's so helpful. You see clients who've been depressed for decades getting a lift of their depression. They're all of a sudden they're getting an introduction to, it can feel different. Think about, Hannah mentioned treatment-resistant depression. So treatment-resistant depression is depression that doesn't respond to, a certain number of conventional treatment like SSRIs and SNRIs. And then these are people with treatment-resistant depression. In the United States, we use ketamine. Ketamine, there's a lot of research that shows that ketamine is very effective for treatment-resistant depression, but it's not for everyone. So Andreas, I'm wondering if you can talk about exclusion criteria, both from a medical and psychiatric perspective.
Yeah, that's a really good question. From a ketamine standpoint, obviously, we're talking more physical stuff, hypertension, thyroid disorders, complex trauma, head injuries, and stuff like that, concurrent sedation and cognitive blunting with things like benzodiazepines. If there's manic episodes, it might be contraindicated, but we have had some pretty good luck getting bipolar patients under control pretty well too. The intracranial pressure thing, obviously, most people who have intracranial pressure problems know about them, but not necessarily. But otherwise, the medical problems, honestly, are fairly simple to deal with. The high blood pressure is probably the more common one. And I always ask all of my therapists to shoot me a message if you're hitting the 160 over 100 mark before you start, And I know we've had a few people that came a little bit close to that, and then we make individual decisions. But from a medical standpoint, it's actually fairly uncomplicated, The biggest thing is making sure the surrounding structure of their mental health care is proper and in shape. And that includes ruling out addiction, ruling out excessive alcohol use, whether it's a use disorder or just use in general, Preparing the patient, just like you talked about the HPPD, I've got a handful of those. And unfortunately, sometimes they're the younger kids, which is a big bummer because it really, really puts a dent on their lives. Sorry, my screen quality is really crappy. Other than that, if you don't prepare the patient properly, you're not going to have luck. It's not going to go very well, and that surrounding component, just like the HPPD, I was going to say, the risk of HPPD is definitely lowered if patients are getting treatment in a proper environment like you guys. The only HPPD cases I have are ones that got shrooms at a concert from a buddy or something.
Yeah.
It's usually the younger kids, and it's very disturbing because it goes on for months. And I've got a couple that are at least a year or so longer now, and I don't know that there's an out. I don't know that there's an out. I told them this might be a permanent situation, which is a big bummer.
Yeah. I think that in recreational setting, people are a lot more likely to get a HPPD because of the setting, right? If you're going to, a concert and your body gives you mushrooms and, everything is scary and no one is there to tell you that, to calm you down, then everything becomes more scary. It kind of reinforces itself and gets more and more and more scary. Whereas if you're in a therapeutic setting, your chances to experience bad trip are very low, slim to none, because there's someone with you, someone who you're deeply familiar with, and they can calm you down.
Yeah. Oh, I was going to say, and again, the research isn't out there yet to say, hey, does HPPD show up? Less common number one, if you have a proper therapist, I think we know that. But what about other supportive treatments, whether it's medications or whatever it is, again, I always put all treatments, all ingredients into the same bucket. One is not more important than other, but the more supportive treatments you have, the more likely you're going to not have adverse outcomes. And you set the table properly, the less likely they're going to be triggered and overwhelmed,
Yeah. Gail, Tiffany, I'm wondering if you have any more thoughts about exclusion criteria from a psychological perspective.
I definitely screen out folks who have a history of like schizophrenia or schizoaffective disorder and their lineage. In their lineage. So like, if it was like their parent or a sibling, doesn't even have to be them. I don't necessarily think that I'm the right fit to do that work with them. Maybe someone else would feel comfortable doing that, but for me, I would not want to activate something. Trying to think of what else. I mean, I have worked with folks with psychosis, with substance use disorder. I have the privilege of working in a medical setting with a lot of other folks present who have experience with those pieces. So it feels okay for me, but only because I work in a team. But if I was on my own, I don't know. I think it can be really tough because you have to be comfortable with saying no a lot. If the vibes are off, or maybe one of the pieces that for me is important is if they have been hospitalized within the last year or 6 years, inpatient for psychiatric reasons. I generally don't take folks on who have just recently been discharged. I think other folks might, but for me personally, I don't feel great about that. So I tend to refer.
Yeah. Tiffany, any thoughts?
So I feel like mine might look a little different. Like I have some people who are externally viewed as very high risk, but also even within EMDR, a lot of times we would say, okay, well, if someone dissociates or someone has active SI, that we don't do EMDR with them. And in my experience, I've been able to actually use that to get them out of those spaces, that if I'm waiting until they're fully stabilized to be able to do that, we're not going to get there. But it goes back to therapeutic relationship, my trust that they are going to reach out to me, that they're going to continue our work, that we get to check in and we get to make sure along the way that this is working for them. So like Andreas and I are working with a kiddo who has a very dissociative system. I do both EMDR and I've worked with this kid since he was 8 years old. He's now a teenager. That it was a different case, like just out the door, someone just like walked in and was like, oh yeah, I want to do this. I would be more hesitant, but when I know a client really well, when I have a really strong therapeutic relationship and we have supports in place, I don't think that some of these things are always necessarily rule outs. I saw someone had put in the chat as far as like BPD. For me, BPD
Yeah.
is a whole lot of trauma, unresolved trauma.
Yeah.
And so that's not an exclusionary for me either.
The exclusionary ones should really be looked as a relative contraindication. Just like when I choose to do some bipolar patients with ketamine and some without, it really depends on the circumstance, their support network, their other supporting medications, whether there's been recent mania, what the recent mania looks like, how destructive it is, because you're balancing it towards what's the risk of not treating them. And sometimes that's worse than the risk of treating them, Suicidal, I had that one gal who we've done everything, and I've had her for at least 10 or 15 years, permanently suicidal ideation. And she finally came out of it with TMS and solid ketamine to the point where it's just turned her life around, And so we can't use hardcore. Again, the medical stuff, yeah. If you have a high blood pressure and you get a stroke, then that's a bad thing, But again, that's a really, really rare problem, Really, really rare. Yeah.
I want to mention I was working with a young woman who had fentanyl dependence disorder. It was pretty risky, and they were trying to get treatment other places, and people were like, "This, I don't want to touch this. This is too scary. I don't, And the clinic that I work with, and this is sort of our entry point, but I was like, "Hey, do you think ketamine could help this person? I don't know. Like, this person literally has tried everything and they're going to die. Like, what can we do?" And so we did, it was like a mixed mosh of things, but it was, ketamine. We did like a twice a week for 4 weeks with Sublocade, which reduced, the opioid dependence, and feeling state protocol, EMDR feeling state protocol. And that person, I'm getting goosebumps saying this, but they have been free of opiates for over a year now, because they've done integration work. But it took some folks being willing to try different things, and they're off the Sublocade, they're off other medications, and it was an integrative approach. And now they pretty exclusively just do Psycholytic EMDR with me, once every 6 weeks or so, even further out now, because that's what they need. They've done all of their high risk work up front in a medicalized setting, and I'm grateful that they were willing to do that. And it does sound like, Andreas, that you might be somebody who would be willing to work with someone who's like, "Hey, this is hard, but how do we work to support this kind of treatment?" Right.
Right. So I run, I have my own practice of 25 years, but I also run 15 methadone addiction clinics in Colorado, New Mexico, and California. And it's all fentanyl. And the old fashioned method was, well, just give them, methadone but that's it. And I told, when we started this, I said, look, that's a 1950s approach. Okay. We must treat the reason why they got addicted in the first place, or you're not going to make any progress. And the board has always kind of stood by this old fashioned adage, never make a diagnosis until patients are off chemicals because it's too clouded. And then SAMHSA finally, heaven forbid, came out a year ago and said, look, guys, we can't always wait until addictions are gone. You have to treat concurrently and do your best job to diagnose what's going on and then go in that direction. You have to, must. The risk of not treating these people, and by the way, this goes from depression, it goes to ADHD. Remember, what's one of the consequences of poorly controlled ADHD? Is addiction. So we have a lot of patients sucking down methamphetamine saying it's the only chemical that allows me to focus on a minimum wage job. Otherwise, I can't even have a life. They're self-medicating. And then they'll say, no doctor will take me seriously because they all call me junkies. And I've even asked the big head honchos at AZAM, I said, how do you guys feel about treating meth addicts properly for ADHD? And they said, well, we kind of frown upon giving stimulants to stimulant abusers. And I said, I kind of frown upon not treating problems properly. That's what I frown upon, because stimulants don't stimulate people with ADHD. It calms them down. It's the opposite. ADHD is a disease of you have defective broken brakes on your truck. You're going too fast. We stimulate the brakes. We're slowing things down. They don't get stimulated. I have exactly zero of like a million meth addicts that I have exactly zero of them that have true ADHD that are abusing or that would ever abuse ADHD medication. It's always the non-ADHD kids that are abusing the ADHD kids' meds. Because the ADHD kids are like, well, I don't really care. It doesn't do anything for me. My mom makes me take it, you know. I'm like, that's the problem. It's not the ADD people, it's the non-ADD people that are abusing them. And I have gotten plenty of people off of methamphetamine by treating their ADHD properly. Okay, so then be more cautious, do more random testing, do more cautious, prescribing. Don't go, try not to use Adderall and Ritalin, try to use Vyvanse, which is more protective long term, use shorter durations, show them some grace for getting through a problem, and then you'll have an amazing outcome. And the amount of treatment we've gotten done has just been unreal. Again, everything is so relative. And I think we get stuck in our little boxes when we come up with these rules that we can't do X, Y, or Z, when in fact, killing yourself from suicide or fentanyl, like, we don't talk about that. Like, well, that's the patient's problem. Well, no, that's actually your problem. That's a side effect of not properly treating, that's on
Yeah.
you.
This is why I love working with you. And I just want to throw out, a few resources there if you want to learn more about this work or you want to do this work. So first thing first, find yourself Dr. Edric. He works in Colorado, but find a local provider who understands your patient, who will be willing to talk and communicate and listen to you. Dr. Edric mentioned, high blood pressure. I had one client one time, I measured blood pressure right before every session and it was high. And I called Dr. Edric and he picked up the phone and he gave me the okay. Otherwise, if you work with one of these big companies that send ketamine in the mail and whatever, then you're not going to get the doctor on the phone and you're not going to be able to consult with them. You're not going to be able to provide patient care. And if you want to learn it more experientially, Gail has a training. Gail, do you want to say a few words about your training?
Sure. So here in Boston, at the clinic that I was just talking about, we do a very comprehensive training program that includes in-person didactic learning and a one-day, it's an optional experiential psycholytic EMDR experience. And that could include psycholytic resourcing. It doesn't have to be targeting a specific event that needs to be reprocessed. And then we have a lot of support on the back end, a lot of information about ethical considerations. It's essentially an ethics training because we go over all the literature and research about how to do this work safely and well and doing no harm. And that will be happening in November on 7th through the 9th. We do still have some spaces open. And then we also run like consultation groups. I do consultation groups for psycholytic EMDR and individual consultation for that as well.
And here, Dr. Edric also put his practice website in the chat for Colorado people.
It's so interesting because it's taken so long to break out of the 1950s type of mentality of how we take care of patients. And if you're not innovative and you're not on the forefront of this stuff, you're going to fail. I ask myself, why are we the only addiction clinic system in the entire country who do complete medical care? I'm talking family medicine, including psychiatry, including everything. Why are we not recognizing that these folks have needs that are way beyond just what you're seeing on the surface? And that includes you guys, the psychology part, the psychiatry part. That's just one component. Of course, yes, we can't necessarily fix their housing situation and their work, but we can certainly try to address any problems that make it easier for them to succeed. COVID, the silver lining for us, the government never allowed telemedicine for methadone clinics. At COVID, they finally allowed us. Then a big study comes out after COVID saying, wow, opioid patients do much better when you combine in-house with telemedicine, because they tried to withdraw that permission and now they can't because it's proven. And all of a sudden, patients are now able to do consults from their cars while they're driving their kids to school or having a life or getting to work or whatever it is. And we're keeping them integrated in life. But it's been such an obvious thing for so long. Why are we not doing the whole thing? That's always my question and my concern,
Yeah, I think big systems take a lot of time. change, right? For things to actually change. And in the psychedelic world, I have to say that I'm pretty optimistic, even though last year MDMA was not approved by the American FDA. We're really seeing a big shift in how the public, medical professionals, experts are perceiving psychedelics. These are not now the dangerous Schedule 1 drugs. They're still federally Schedule 1 drugs, but which interestingly in the 50s they were all legal and there was a lot of research done with them. And then in around 1970, all of them went kind of, this is dangerous, and it's now they're in the same category as meth and heroin. But this is really, really shifting. I was leaving one of the lectures and I saw Bessel van der Kolk just standing there being on his phone, like he was at the conference. Like all these experts are endorsing the use of psychedelics and recognizing, and there's tons of science. There's so much science from all over the world showing the benefits of these medicines. Hannah, do you do consultations?
Yes, I do. Yeah.
Okay. So Hannah do consultation. Tiffany, you do consultations as well, right?
Yeah. No, I've still got some room for that. I've decided to run for mayor. That's why he's laughing at me. But no, I still have room.
You're amazing. You really are.
I think it's awesome.
All right. Thank you all for joining us. Thank you, panelists.
Thank you guys all for doing a phenomenal job, man. I always want to be a fly on the wall one of these days, I don't get to see it from your angle, but it's amazing. Thank you guys.
All right. Thank you all.